Hello.
Hello.
We are now live.
We're live. This is the Senate Health and Welfare Committee, and we're back. We're going to be looking at two bills that have come to us from the House. The first one is H206, and it is a bill relating to Department of Vermont Health Access. And Representative Goldman, thank you for being here. You're the reporter of the bill.
Yes, Leslie Goldman, Representative Leslie Goldman for the record. It's a pleasure to be here and meet two new senators.
So you don't know, so.
Yeah, we just met.
Oh, you did meet. Okay, we're good.
Yeah, appreciate that. So H206 is the annual housekeeping bill for the Department of Vermont Health Access, or known as DVHA. DVHA. It's a strike all amendment that proposes four things. It was voted out of the House Health Care Committee 901. What it proposes, section 1, it specifies that exceptional medical circumstances under which DVHA may approve expenditures for dental care in excess of the adult dental coverage cap, including emergency dental services as defined by DVHA by rule, and it removes the cap for certain individuals. And I can go deeper into these if anyone has questions, but I'm just.
So, I think
summary.
the high level, and then we're gonna go through it with Ameren.
Yeah.
So we'll be good.
So I'm just good. So that's section 1. Section 2, it specifies that for items or services for which Medicaid paid for, but which another insurer actually should have been responsible, the insurer is required to accept DVHA's prior authorization for that item or service covered in Vermont's Medicaid program that satisfies the insurer's prior authorization as required by the Federal Medicaid Act. And that's the one I had the hardest time with, so Ameren will help with that. Section 3 allows a designee of DVHA's medical director to have the same query access to the Vermont prescription monitoring system as the director does for purposes of Medicaid quality assurance, utilization, and federal monitoring requirements. And section 4 requires DVHA to collaborate with representatives of Vermont's federally qualified health centers to develop mutually agreeable alternative payment methodology for Medicaid payments to FQHCs. And a progress report is due to the House Committee on Healthcare and to you by December 15th, 2023. Section 5 is the effective date, which is July 1st. And we heard from the Director and Chief Counsel, Office of Legislative Counsel, Director of Communications and Legislative Affairs, Department of Health Care Access, and Deputy Director, Vermont Medical Society, Chief Healthcare Advocate, Office of the Healthcare Advocate, Vermont Legal Aid. And as I said, it was 901. So 4 features of various different things.
Okay. And
Housekeeping.
housekeeping. And then the vote on the floor was.
Oh, it's a voice vote.
Yeah, okay. Questions, committee? We'll go through it thoroughly with Ameren too. Okay.
So the insurers, the item pertaining to the insurer's obligation versus the state and the recipient of the care, how does that get conflicted? And why isn't the insurer and the person who's receiving the benefit? How is the state getting involved?
Well, I think let me make sure I get this right, that a person who has Medicaid, circumstances may change. They get a job, they get another insurance, a spouse gets insurance. So they have these 2 different insurances both at the same time. The Medicaid is the insurer of last resort. So the other insurer from the job or whatever has to pay first.
Okay.
Is that
is an example.
okay?
Oh, wait, I guess.
We'll let Amber
Okay,
get.
yeah.
Okay, thank you.
So it is it's
It's pretty technical.
little technical, but
Yeah.
How about JFO financial summary, anything?
There was no financial impact at all. In the dental piece, there was movement of money from Dale and Department of Mental Health to increase the dental, and I can tell you the dental coverage if you'd like to hear that, how that changes. So right now, currently Vermont Medicaid provides coverage for medically necessary dental services for adults over 21, provided by dentists, dental therapists, or dental hygienists within the scope of the provider's license. There are preventive services but those don't count towards the current annual cap, which is $1,000. Okay, so that's Medicaid's cap. House Healthcare and our, and DEVA have proposed increasing the annual cap to 1,500, so that may be coming to you in your budget. 206 is going to allow DEVA to expand coverage in 2 areas. It'll cover emergency dental services for Medicaid enrolled adults beyond $1,000 when exceptional dental emergencies are present, as defined by rule, and exceptional circumstances may include bleeding, infection, or pain. So that'll expand that beyond the cap. And it also expands coverage to include dentures and other medically necessary dental services without an annual cap for adults in the developmental disabilities program and the community mental health and rehabilitative treatment Medicaid program. But because the money is moving over from DMH and Dale, there's no impact.
Even though the cap is lifted.
That is, yeah, that's within the Medicaid budget.
Currently within the Medicaid budget
Mhm.
for the state.
That's right. Yeah.
Good, thank you.
And we'll hear from DEVA and to clarify some of
So we're not doing a vote on this? 20 minutes?
it. We're not there.
No, you're just starting.
Thank you.
Yeah.
Okay. Thank you. Any other questions for Representative Golden? Thank you.
so much.
Good work. So Amron, we'll let you walk us through the deeper dive.
Good morning, for the record, Amber Navajali, Legislative Council. Would you like me to share my screen for the walkthrough?
Sure. That'd be great.
This is H206 as passed by the House, an act relating to miscellaneous changes affecting the duties of the Department of Vermont Health Access. The first section is related to Medicaid coverage for adult dental services. We're amending section 1992 of Title 33. So I will read part of the current language for context. So subsection A, Vermont Medicaid shall provide coverage for medically necessary dental services provided by a dentist, dental therapist, or dental hygienist working within the scope of the provider's license as follows. Then you'll see there's an addition within subdivision 2. So 2A, and this is current law, diagnostic, restorative, and endodontic procedures to a maximum of $1,000 per calendar year, provided that the Department of Vermont Health Access may approve expenditures in excess of that amount when exceptional medical circumstances so require. So then we have new language saying that exceptional medical circumstances include emergency dental services as defined by the department by rule. So DEVA will be able to establish what is considered emergency dental services. And then subdivision B, also new language, the following individuals shall not be subject to the annual maximum benefit amount as set forth above in subdivision 2. So individuals served through the Community Rehabilitation and Treatment and Developmental Disability Services programs pursuant to Vermont's Global Commitment to Health Section 1115 demonstration. And 2, Medicaid beneficiaries who are pregnant or in the postpartum eligibility period as defined by the department by rule.
Just curious, page 2, section I, is there a count? Is there a number of folks that we know that are in this category? Is there any kind of just kind of put a scale to it?
I don't have a number, but the Department of Vermont Health Access might.
Thank you.
So is that the one that came over to us from the House, that bill?
Yes.
Yeah, the bill is introduced.
Oh, no, I picked it up in the hallway
Oh,
outside.
yeah, that's the bill is introduced, so there might be some slightly different language that when it came over. Yeah, just,
Section 2 is concerning Medicaid being the payer of last resort, as in a Medicaid beneficiary has medical services, and also is eligible for insurance coverage through some other means, either through, you know what, I think I might let Department of Vermont Health Access, if they are prepared to, today or at some future date, talk about all the different types of insurance that someone might be covered. An easy example is that someone may be dual eligible for Medicare or Medicaid, but there are other circumstances where someone might be covered by insurance that has a health insurance piece to it, in which case federal law always requires that Medicaid is the last payer. But someone may go in for services, Medicaid, they know they have Medicaid coverage, Medicaid is billed for those person's services, and then under federal law, Medicaid is obligated to go to the other insurance and say, we paid for it, but now you need to reimburse us because we're the payer of last resort. So adding on to that, this section 2, both section 1908 as well as 1909 concern the circumstances where an insurer has a prior authorization requirement before they would cover the services. And are you familiar with prior authorization requirements? Does that generally sound familiar? Okay. So this is dealing with that specific circumstance where the insurer has a prior authorization requirement, the Medicaid beneficiary went, got services, and Medicaid was billed. And now Medicaid is going to the insurer saying you need to be reimbursed. So section 1908 of Title 33, Medicaid Payer of Last Resort, Release of Information. So there are some technical conforming changes here to our drafting style. So except is becoming capitalized in that first section. But subsection D, on or after July 1st, 2016, an insurer shall, and I'm going to scroll down onto page. Yes. Onto page 3, if the insurer requires prior authorization for an item or service, except the agency's, in this case, the Agency of Human Services, authorization that the item or service is covered under the Medicaid state plan or waiver, as if such authorization will be insurer's prior authorization. So an insurer cannot say, there's no prior authorization, so therefore we can't reimburse Medicaid, because we require a prior authorization. And this says that the insurer has to accept the Agency of Human Services authorization saying, yes, it's covered under the Medicaid state plan or waiver. And so the insurer will need to treat that authorization as if it were the insurer's own prior authorization.
So can you give an example of when an individual would be under the umbrella of a private insurance, and on them also how this works with Medicaid?
If possible, I would like to defer to Diva on that.
Okay, we'll defer to Diva. That's good. Okay, we'll do that.
And then section 1909, direct payments agency discharge of insurer's obligation. This is sort of a continuation of what it happens in section 1908. So this section concerning discharge of insurer's obligation. In subdivision 3, you'll say an insurer shall not, at the bottom of the page, first, deny a claim submitted to the agency solely on the basis of the date of submission of the claim, the type or format of the claim, failure to present proper documentation. This is all current statutory language. And then this bill adds the addition that an insurer shall not deny a claim submitted by the agency on the basis of failing to obtain a prior authorization for the item or service for which the claim is being submitted, if the agency has transmitted authorization that the item or service is covered by the Medicaid state plan or waiver under subdivision 1908 D2 of this title, which is what we just covered being added, right? So first we're saying in the last section that Agency of Human Services authorization saying this is covered under the state plan, the insurer has to recognize that as if it were their own prior authorization. And then in the second section, therefore we say the insurer can't deny a claim because there was no prior authorization for the item or service. Because we're saying the agency's authorization is the prior authorization.
During testimony, is it?
We're gonna have to hear testimony on this, definitely, yeah.
This is a question maybe for both of you. Representative Goldman referred to this as a housekeeping bill. Is that an accurate assessment of this bill?
How people define housekeeping is different, I would say.
Yeah.
It will have an effect. It will change the authority between the private insurer and DEVA. There will be some.
There are instances where people refer to something as housekeeping if the change in the law is substantive, but in practice, it is not changing either what is currently in practice or what we're requiring in statute is required by federal law, in which case there's no option to do it or not do it. So I think you can probably, when you hear from DEVA, you can hear what is the state currently doing, what are they allowed to do under federal law, why are these changes happening, and that will help you figure out whether you consider this to be housekeeping or not.
Okay, thanks.
Because we don't have a definition of what is housekeeping and what's not.
Right,
So
right.
it's-
Yeah. I mean, I almost, when I think of housekeeping, I'm almost thinking of like some technical fixes.
Technical corrections, right?
Yeah, and this seems like maybe it's a little more than that. I
We'll
don't know.
find out.
Yeah, okay.
Yeah.
Policy baked in.
You're right, okay.
Yeah,
So section 3 switches gears entirely. So now we're looking at the Vermont prescription monitoring system. So section 3, subdivision C, okay. So section 3, we're amending section 4284 of Title 18, protection and disclosure of information, again, within the Vermont prescription monitoring system. The department, in this case, we're talking about the Vermont Department of Health, shall provide only the following persons with access to query the Vermont prescription monitoring system. You have A, which is our providers, dispensers, delegates. This is for the purpose of providing medical or pharmaceutical treatment. B is personnel or contractors as necessary for establishing and maintaining the system. And then C is the medical director of the Department of Vermont Health Access. And now we're adding in the words and the director's designee for purposes of Medicaid quality assurance, utilization, and federal monitoring requirements with respect to Medicaid recipients for whom a Medicaid claim or a Schedule 2, 3, or 4 controlled substance has been submitted. So that is adding a person who is able to query the Vermont prescription monitoring system. Presently is only a director. Section 4, federally qualified health centers, alternative payment methodology report. Again, we are switching gears and now we're talking about alternative payment methodologies for Medicaid. The Department of Vermont Health Access shall collaborate with representatives of Vermont's federally qualified health centers, also known as FQHCs, to develop a mutually agreeable alternative payment methodology for Medicaid payments to the FQHCs. On or before December 15th, 2023, the department shall provide a progress report on the development of the methodology to the House Committee on Healthcare and the Senate Committee on Health and Welfare. And then the last section, 5, is the effective date section. And so this act shall take effect on July 1st, 2023.
okay, so there are some questions in here for us. So we're gonna need to hear from DEVA, Department of Health on the VPMS and the FQHCs, and probably a couple others. We'll see what we need for this. And then I did ask Ameren for some language on a couple of an amendment that I'd like to bring into the committee that probably the next time we look at 208, 206, 206. So that would help. And I think so the amendment would include some language on the 340B sunset, on Blueprint, and then possibly the hospital lien bill that has been through judiciary, but might fit with this one. We'll look at those when we look at the bill next time. So, and if you have folks, I just named the 3 I thought popped out for needing to have in for testimony, and we'll see what else we need to hear. Okay, thank you. And so Representative Chena is here. And we're just gonna keep moving along just because of the day. It's moving along faster than we are. And we have H481. If you can give us welcome.
You got thrones down here. Wow, look at this. King of
Just
the
for you.
castle.
I know.
You are.
I don't think so. So we're looking at H481.
Yes, and Katie's here too. Do you want me to just say the premise and then Katie will do the walkthrough?
Yeah.
Okay, great.
You just give us the,
Yeah, like
yeah.
so I'm Representative Brian Chena for the record of the House Healthcare Committee, and I was the reporter of the bill H41. Can we put it up there at least? Is that possible?
Yeah.
Just so I'm not gonna do a walkthrough, but just so that I can say the title correctly. I think it's an act relating to prevention of death by suicide.
Preventing death by
I
suicide.
was not too,
Yep,
yeah,
you were
this is
very
too wrong. So an act relating to preventing death by suicide. So I'm looking around and some of the senators are new. Like I know Martine, but I don't think we've ever actually been properly introduced.
Oh, okay,
Yeah.
so we only introduced on the screen, so let's do that right now. So
Yeah.
We'll start with Martin.
Hi.
Senator.
We know
Dorr.
each other.
Yes.
Dave Weeks from Rutland, representing Rutland.
Yeah,
Terry Williams from Rutland, or from Pulte. representing
yeah, Rutland County,
Yes.
yeah. So, over the last, I've been here 7 years, we've been talking about suicide prevention because suicide rates have been increasing. And the state has taken many initiatives to try to address, this public health crisis, I would say at this point. During the pandemic, suicide rates skyrocketed. They got worse, just like overdose rates. And the state hired a suicide prevention director, I believe is his title, and as part of the Department of Mental Health. And there are many initiatives that the Department of Mental Health is working on related to suicide prevention. I'll give you one example, but I don't want to take too much time because I think you might hear from some witnesses who could do this. One example, I am a licensed clinical social worker and I'm a crisis clinician. So I have a private practice and I'm a crisis clinician. The state has been offering a training at a reduced rate for clinicians called CAMS, Collaborative Assessment and Management of Suicidality. And so I took advantage of it as soon as it was available because I wanted to try what we're offering to the providers. And it's an evidence-based practice that's been extremely effective. And so that's one example of what the state has done, subsidized training. So providers still pay, but it's not as much as it would have been, as an incentive for us to do the training so that we can improve the treatment of suicidality. And so that's one of many initiatives that are going on. And so as we were taking testimony on the issue, we were also talking about access to lethal means. There's an approach to counseling called counseling about access to lethal means, where when you talk with a person who's experiencing suicidality, you talk about the different ways they're thinking of doing it and how you can reduce access. And one of the most lethal mean, I would say, is firearms. So we would in that approach, you might say to a family or the support of a person, how do you work with them to lock things up, like knives, medications, secure firearms, etc. So there's all kinds of stuff that we are doing on that end in terms of the providers, but there was also talk about what the state needed to do around other firearms restrictions. And in that discussion, a lot of ideas came up. There was a lot of talk about a lot of things, and we decided let's separate them. So there's a firearms bill none of that is connected to this bill. So we separated the firearms regulations and laws out and looked at what was left and determined that we would codify the position of suicide prevention director and identify some of the initiatives we want to make sure they look at and report back on next year so we know where to continue investing money. So I just share that because we looked at the issue in the big picture and then we decided there would be two bills. One would be just firearms because we know that that's a sensitive issue for Vermonters. And one would be what the Department of Mental Health is doing. And it involves the department it involves the agency. Let me let me clarify, the Agency of Human Services is doing and the Agency of Education, because it's not just the Department of Mental Health. We're looking at suicide prevention across the entire Agency of Human Services and the Agency of Education in this bill. So I want to make sure Katie can talk through the language, but just to paint the picture, and in summary, we've been working on suicide prevention for many years. It's a big problem. This bill codifies a position and gives some direction to that position to come back to us with sort of a plan and a strategy or an updated strategy, because we've had one. We just have to step it up a notch. And the staff are there and they're ready to do it. And this is our way of supporting them in that work so that we can save lives and prevent death by suicide.
Thank you.
Yeah.
Question?
Thank you for that. The three of us are all on the Ed committee.
Yeah.
So when you bring up the AOE.
Yeah.
And maybe Katie will be speaking to this more granularly, but can you give us like a broad?
Yeah, I can give you a broad, and then Katie can get into the language with you, and any legal questions, but, in terms of just like the policy perspective, we are that for youth. They might, I would say like, schools are probably the second most influential place in their lives, if not the first for some kids, you know, that they're in schools, they're around a lot of adults in schools. When there's problems related to suicidality, it comes up in the schools, and we heard testimony about what the education system is doing and is not doing. And so we are in this bill asking the suicide prevention director to work with the Agency of Education on assessing practices and kind of coordinating and creating some protocols and some providing support to the schools. This does not mean that people are not getting help in the schools. Our schools are handling a great burden right now of the mental health of youth. This is about us finding out what they need and making sure we can support them and making sure that the kids are taken care of better. So I think that's and then you can explain the details of the law, but I think that's the kind of concept so we did hear from the Agency of Education, which we don't always do in healthcare.
No, but it's good to do that. Yeah.
Yeah.
That's great.
Thank you.
And you know, just not to go off topic, but we heard the health equity recommendation about a
Yeah.
government approach. That's what we're talking about here. It's like,
Right.
why focus on just one piece of an agency when all human services could be, you know, the entire agency, and likewise with education? Like, why not prevent suicide across the systems of government where people are having contact with government?
Thank you.
Yeah, all right, I want to, yes, I'm sorry.
Okay.
I'm happy to talk more. I just want to be mindful of leaving time.
It's a short bill.
It's very short, but it's a big issue.
So, in summary though, it's creating the director position?
No, it already
Or-
exists, it's codifying it. So it's,
What's the difference?
the difference is, and Senator Lyons could probably explain it better than I, because she's been here longer, but let me try, like, that, the executive branch has the power to create task forces of its own and positions of its own, and we have the power to make them do it. And in this case, the executive branch chose to take action, and we're saying, we agree, we're gonna put this in law, and we're gonna put our 2 cents in, and we're gonna give some direction, give some guidelines, but we did this in collaboration with the Department of Mental Health and Testimony, so there's total agreement here. This is a bill that passed unanimously, you know.
And then second bit is it's a study to create a strategic plan statewide for suicide prevention.
Yeah, I don't know if I'd say it's a study, because it's ongoing work. It's more like we want to report on that work, and we want it, and we're telling them we want it to be coordinated. So I don't know if it's less of a study and more requesting a formal plan.
Yeah.
Okay, there. So-
We'll get it.
Yeah.
This is good. Yeah.
And then 988 versus 211 for suicide.
The
prevention.
difference?
Yeah.
Yeah.
So think of 988 as 911 for mental health when you don't need to go immediately to the hospital, and if you do, they'll put you through to 911. Whereas 211, you call 211 and it's like, you know, you can ask any question and they'll try to answer it. 988 is like, I'm in mental health crisis, I'm suicidal, I'm not okay, I need to talk to someone, and then they would assess in that phone call, you know, should we put you through to a local agency? Can we handle it? Do we put you to the peer support line? Do we call 911 and send them to your house because you need to go to the hospital? Right before 988, every county in the country was supposed to have a crisis line. And Vermont does have these. In each county, designated agencies are usually the ones who manage it. And that's actually one of my jobs is, when I said I was a crisis clinician, it's for the Chittenden County Crisis Service. But what 988 has done is created one national number you can call anywhere in the US and say, I need help. And then they will figure out, where are you? You know, who do we put you through to? So it's a national initiative.
Okay, good.
Yeah.
Thank
And I'm
you.
gonna be right here. Can I have a peppermint patty? They've been like tempting you all the
Yeah,
time.
yes,
Right.
you
Or you
may.
work wherever
That's
it
your
is.
reward. That's your reward. So Katie, go through the bill.
So we had Adam.
Oh, Adam?
Go ahead
Why
and
don't we
talk
go
to the bill, if that's still okay.
Okay, terrific, excellent.
I'm sorry.
Oh, you're fine.
So, and I think you probably know everyone at the table, but everyone doesn't know you.
For the record, then, my name's Adam Washburn. I'm a student clinician with the Office of Legislative Counsel. Means I'm working under the supervision of Katie, and I'm a student at BLS currently.
Is this your first report?
No, it is not. It's my third. So.
Oh.
Done with big
He's
walk
an old
already.
hand.
All right. Well, you guys heard from Ameren before me, so I'm going to try and match the eloquence of her walkthrough to the best of my ability. And just we'll dive right in. I'm here to talk about H481, which is an act relating to public health initiatives to address death by suicide. As a quick overview, Section 1 outlines the Director of Suicide Prevention's duties under this bill. Section 2 sets out a strategic suicide prevention plan and school protocol initiative. Section 3 requires a presentation on the state's work on the CDC's comprehensive suicide prevention grant. And then Section 4 will be the effective date. Starting with Section 1, 18 VSA Chapter 192 is added in Title 3, Preventing Death by Suicide. Section 8151 sets out the duties of the Director of Suicide Prevention. The Department of Mental Health's Director of Suicide Prevention shall lead the state's suicide prevention efforts, intervention supports, and post-vention efforts, and collaborate with communities and providers to reduce the number of suicide deaths and attempts in the state. The Director shall promote and support statewide crisis and suicide prevention recommendations as outlined in the state suicide platform, including the creation of a strategic plan and suicide prevention education protocol for all schools. Director shall expand partnerships, implementing innovative data-driven initiatives. We go to page 2 real quick. Coordinate suicide prevention programs across the state and work to secure federal funding. Section 2, titled Statewide Suicide Prevention Strategic Plan and School Protocol. Subdivision A1, on or before July 1st, 2024, the Director of Suicide Prevention, in collaboration with the Agency of Human Services and stakeholders, shall develop and submit a statewide strategic plan pertaining to suicide prevention services, training, education, and post-vention services to the House Committee on Healthcare and to the Senate Committee on Health and Welfare. The statewide strategic plan shall identify goals, possible partners, and strategies for meeting clearly defined targets in the prevention of suicide. Key resources and gaps shall be identified, including sustainable 988 lifeline funding, zero suicide program expansion, improved data collection and reporting to identify contributing causes, including social factors to inform prevention strategies, and data-informed systems and strategies for establishing and maintaining post-vention services within communities, schools, and healthcare systems. Subdivision A2. Prior to the submission of the strategic plan required pursuant to subdivision 1 of this subsection, the Director of Suicide Prevention shall submit quarterly progress updates on the development of the strategic plan to the House Committee on Healthcare and the Senate Committee on Health and Welfare between July 1st, 2023 and April 1st, 2024. In the January 2024 progress update, the Director of Suicide Prevention shall include preliminary budget recommendations and sustainable funding plan for 988 Lifeline. To summarize the last 2 paragraphs, the first one creates the development of a strategic plan, and second is to submit quarterly progress updates on that plan. Subsection B, On or before January 15th, 2024, the Director of Suicide Prevention, in collaboration with the Agency of Education and stakeholders, shall develop and submit a model protocol for all schools regarding suicide prevention, education, and post-vention services to the House Committee on Health Care and to the Senate Committee on Health and Welfare. Section 3, titled Presentation, Comprehensive Suicide Prevention Grant. Subsection A. On or before February 1st, the Department of Mental Health, in collaboration with the Director of Suicide Prevention, shall present information to the House Committee on Health Care and to the Senate Committee on Health and Welfare regarding the work accomplished by the state in accordance with the Center for Disease Control and Prevention Comprehensive Suicide Prevention Grant, including the results of the Complete Suicide Data Linkage Project. Subsection B. Prior to the presentation required pursuant to subsection A of this section, the department shall submit the results of the Complete Suicide Data Linkage Project to the House Committee on Health Care and to the Senate Committee on Health and Welfare as soon as they are available. The Suicide Data Linkage Project looks at suicide deaths in Vermont between 2020 and 2021 to understand risk factors and interactions between these occurrences. Finally, section 4 is the effective date. This act shall take effect July 1st, 2023.
So you just said some dates between 2021 and 2024. Where are those dates?
Those are just in the Suicide Data Linkage Project. Those are the dates that they gather data from for the project.
But they're not in the bill.
Not in the bill, sorry.
Yeah, I thought I wasn't seeing something here. Okay. All right. So, thank you. Questions here. So they're developing a strategic plan and then beginning to act on that plan and reporting back to us on what it is that's happening, including work with a model program for schools on suicide prevention. Work.
Yeah, it is. I'm not sure who this is a question for, maybe Brian, but the fact that we don't have a permanent commissioner of education right now, do you see that as being stymieing some of this work at all, or is that going to be an issue?
I have faith in all the other staff.
Okay.
That's my personal feeling. Okay, because I have a lot of confidence. I don't know if they can see me on the record talking today. I have confidence in the suicide prevention director and in the staff at AOE and the Agency of Human Services to handle this. I don't know if a commissioner would be that involved in this micro level work anyway. That being said, we probably should get a commissioner of education just because it's good to have leadership. So, but I don't think it's going to interfere with this. Like, I think that this work's already happening, and that the people on the ground working with the people in, I don't know if you call it the central office of AHS, the central office of AOE, could figure this out without a commissioner.
Thank you.
So you actually raise a good question about the fact that the coordinator or the suicide prevention position currently exists, so there is work going on.
Yeah.
So now it's a matter of consolidating that into statute and then getting information back so we can continue working on this. Sending them.
Twice in here, Ms. Billy talked about stakeholders. Who are the stakeholders? Says the Director of Suicide Prevention, collaboration with Agency Human Services and stakeholders.
Yeah, we left it intentionally vague because there's so many stakeholders. There's something outside the window. I don't know what's going on, but. Okay, I'm sorry. I just with everything going on in the world,
Yep.
you know what I'm saying? Like, what is happening outside the
yeah.
window right now?
Yeah.
It's just, for people who are watching, there's like a big white thing outside the window blocking it. And that kind of, people blocking the window makes me worried. I'll give you some examples though. For the Agency of Human Services, stakeholders might mean healthcare providers. It might mean advocates on behalf of patient advocates, consumer advocates, patients themselves. It could mean the executives of healthcare organizations.
The designated agencies.
The designated agencies, the specialized service agencies. Those are all stakeholders of AHS. I guess I would even go further. Incarcerated people are stakeholders in AHS.
People
people with
with,
disabilities, those elders, children, all kinds of people who receive services. Consumers are stakeholders as well. And then, and for education, it would be the school districts, the principals, the teachers, probably the unions, the students, the families.
Okay,
Yeah, yeah.
kind of nebulous.
Yeah, we want, and I think our intent is I hate the word robust, it gets used too much, but inclusive, robust, community engagement. Because that's the answer here, we need to build community if we really want to prevent suicide.
During your review of the bill, Representative Chena, who did you take testimony from?
I have to look at the
we'll
witness
go.
list, I have it, if you want me to read it to you. It's
No, I'm
not
just
that-
curious,
well, it is
like, you know,
long.
who are the big hitters?
Yeah, well,
Most significant
we heard from people from the Agency of Human Services, various, when I say people, various positions, like, we heard from the Suicide Prevention Director himself, but also like, the various secretaries and deputy, secretaries, and, we heard from people who had experienced, loss of family members by suicide. We heard from advocates, we heard from lawyers like Ledge Counsel, we heard from providers. So we heard from a lot of stakeholders, basically, but I do have a list and I can send it to the
we have
committee.
the list, it's on your webpage.
Okay,
Yeah, we got it, and we'll look at it.
we definitely took a lot of testimony though. We heard for AOE, we heard from people, what I will say is I don't think we heard from any teachers directly for AOE but we did hear from parents of students who died by suicide, at school. And so it was pretty sad testimony, so we, we heard from people who are impacted at all levels, by this problem.
So I guess the question is that you're focused initially here on education, so more on kids. But in reality, the bill is about preventing suicide overall, so inclusive of adults. So that you had to get.
Yeah, just to clarify, when I say parents, there were parents of grown people too.
Yeah,
So it
no,
wasn't
no,
just
I
children,
understand.
Yeah.
You
Yeah.
looked at the whole,
Yes, the whole age range. And suicide, if you look at the rates of who it's affecting, it affects everyone, but there's certain groups that it's affecting more. Like rural, white, older men. I know that, like, I'm not pandering to like the Republicans from LA County here, but rural, older white men, And I don't know about your history, but veterans have high, I don't know if either of you are vets or any of you are vets, but like veterans have high suicide rates. People with disabilities, there's a few groups that like we saw, I'd have to look at them, that, and so it's just to put it out there, that it's not, although like, I said parents, and I talked about schools, that we're seeing it, that it's not like it's just with youth that there's a problem. There's a problem across all populations, and there's certain populations in Vermont where there's a higher rate than others. And then I'll just put this out there, even though this isn't the gun bill, that what we did learn is that the overwhelming amount of fatalities are when there's a firearm. Like 80 to 90%, I don't remember the exact statistic. And I think that speaks to just how effective firearms are at ending life. That's why people use them to hunt, or in war, because it's an efficient way to end life. And so reducing access to firearm can save lives with suicide, but we did not touch that in this bill. Although, while I'm talking about it, I will throw one idea out there that isn't in the other bill or this one, but could be something that the Suicide Prevention Director could look into, and was the idea of like when we're educating, once we develop ways, like a protocol for schools and ways to like coordinate suicide prevention efforts across the state agencies, we may be able to offer that to the private sector. So gun retailers, for example, could be offered training in like how to see the signs of suicidality in that moment. And what can you say to a person, or what can you ask before you sell them the weapon, to what help you can offer. We even talked about having signs in gun shops, but none of that is in law. These are just ideas. It's like, how can the state be a partner to businesses so that business owners have more skills and feel more confident when they see warning signs of suicide, how to help someone.
Thank you.
The Vermont Federation of Sportsmen Club had a suicide prevention project they call the Gunshot Project. That might fit into what you're talking about.
I think someone mentioned that along the way and it sounded like a good thing. It sounded like a good
very good.
program, yeah.
Thank you.
Thank you. Any other questions
job.
for Adam or Representative Chena? You've been really helpful.
And I'm sorry, I didn't know you were presenting it.
No.
I would have said Adam.
You're not enthusiastic about this bill at all.
Right.
No.
I'm enthusiastic.
No,
in general.
About everything.
All right, we're good. I think that'll be
Thank you.
it for today. And
Thank
this
you.
looks like a bill we will take up.
Mhm.
And I guess the question would be for you, for the education committee is, do you also want to take it in and have, I'll talk with your chair. maybe,
Yeah.
Or you can talk with your chair about whether or not you'd like to look at it in there.
There's moisture right there.
Yeah, okay.
It sounds good to me.
Yeah.
It's just a timing question at this point.
Yeah.
Yeah.
This was
All right,
Sure.
so tomorrow,
that's
just as a heads up, tomorrow, we're gonna try to vote on H-190. And we will be looking more in depth on H-222. There is an amendment that has come from judiciary and the House members and others. So we'll be looking at that amendment on H-222. We won't vote on it, I don't, because we're just gonna see the new language. And then we'll keep going with the bills that we have.
Sounds
We
good.
don't, we're